So good morning again. So good to see everyone here. Big thank you to Kate Daniels, who is here with us today, and is going to be speaking on hospice and palliative care, misinformation, and myths debunked. And Kate is a veteran in the hospice world with 14 years of experience guiding seniors and decision makers in the art and science of hospice and end-of-life care decisions. And I will let her give a further introduction. And Kate, I thank you again so much for being here and for sharing your years of experience with us. So Kate, please go ahead.
Thank you, Anna, and thank you everybody at Aging Together. Wonderful partnership extending across several counties that we really appreciate everything Aging Together does in the community, for the community, and with those of us partners that try to advance the mission of helping the seniors that we care for. So I'm Kate Daniels. I work for a company by the name of Gentiva Hospice, but really I'm going to talk more in generalities of what hospice and palliative care really are by definition and by use. We're going to talk about some of the myths and misconceptions that are that surround hospice and palliative care conversations and what folks in the community could benefit from these services. I'm going to start with a brief story, and we are definitely going to have time for questions at the end of my talk, but I wanted to start with a brief story. I'm going to talk about a family that I recently met who's had several hospice stays. I think they had 6 hospital visits in the last 4 months, with things ranging from pneumonia to a COVID to a urinary tract infection to a suspected mass in the person's bladder, and then 2 falls. So these are things that we hear about a lot in our fragile population of seniors. We hear about falls, we hear about urinary tract infections, pneumonia, COVID infections, things of that nature. And while it does happen to healthy people, it also happens to people more frequently when they're reaching this fragile stage around six months life expectancy. I think sometimes we as a medical community are focused on curing, and we're focused on fixing, and that's what the hospital is designed to do. But at what point does hospice and end of life care come into the conversation? Would it surprise anyone to know that this gentleman is 95 years old, has had 6 strokes, has chronic obstructive pulmonary disease and heart failure? And he's been in the hospital all of these times in the last several months, and his family was continuing to choose to treat everything as best it could. Then he went to a rehab facility. And the way it works at the rehab facility is that you have Medicare coverage for rehab only, right? Medicare will pay for that. And then if you're fortunate enough to have a secondary insurance that might pick up your copay after those initial 20 days that Medicare covers at 100%. These are things that some of us in this room know a lot about, and some of us might not, but these are things that the general public definitely does not. How does it work, right? Who pays for what at this stage? Well, this family decided to keep their loved one there even after the first 20 days of rehabilitation were over, and let their copay be picked up by their secondary. So they were feeling good that he had 100% coverage, and he was being cared for in a skilled nursing facility and getting some rehab. All the while, he was continuing to show signs of decline. He had some more skin breakdown. He had another bout of pneumonia. He had, the wife had COVID. She got COVID while she was at the nursing facility visiting him. Several things happened during this covered stay, and he really was not making improvements, but it was covered. So the family felt good about that. And I totally understand that, we want the medical system to be able to help us when we need it. So about last Friday, they talked to their pastor, who was a friend of mine, is a friend of mine. And their pastor said, you should really, really talk to somebody about hospice and palliative care for this gentleman. And they at first were like, oh no, everything's fine. We're just going to bring him home. It's going to be great. And the pastor said, no, really, just give Kate a call and let's, set up a talk. So I began a conversation with them and answering questions about what is hospice and palliative care. And the more I learned about this gentleman's situation, the more I believed that we could help at this time. The time was right. And that's the nuance of some of this as well, is getting the timing right. When is it appropriate? The truth is, we could have helped this gentleman long before now, and he might have had a different experience. But the good news is we were able to bring him home from this facility yesterday under hospice care, and he's receiving nursing visits at home, a social work visiting, a chaplain visiting, home health aides visiting, and providing care on a routine basis under his insurance. His wife is happy to be home. She was visiting the facility every day, all day long, from 8 to 5, and the daughters were coming from 5 to 9 p.m. So we had visitors almost around the clock. But now they're back home together, and they don't have, a lot of strangers and staff coming in. They have a hospice team coming in, and he's comfortable and his needs are being met at home. And the wife is very, very happy. I don't know how long he's going to be with us, because no one can know that. But I do know that they're much happier as a family having accessed hospice care at this point in their journey. And I don't know how long he's going to be with us, but his needs are being met in the home setting. So I had some questions prior to this talk about what's the difference between hospice and palliative care. And I'd like to talk about that with you all for a little bit. And this is where I do have a couple of slides for you. Palliative care is focused on helping you improve your quality of life. You can even improve your response to existing medical treatments. It gives you a team of experts to help you navigate the emotional and psychological challenges brought on by serious illnesses of life-limiting condition. Palliative care can be provided in a home, assisted living, or skilled nursing facility setting. So palliative care is different than hospice. Palliative has a few different components, and it is also something that you can access while trying to accept curative treatments. So you don't have to give up something that you believe will help you, or your physician believes will help you in a curative nature. But it's definitely going to address pain and symptoms. I'm going to the next page here. Palliative care works collaboratively with your current healthcare providers to ensure each aspect of your treatment plan and care is communicated and coordinated effectively. It's unique in that we specialize in assisting patients with their serious illness journey by helping relieve symptoms that may include physical or emotional pain, fatigue, loss of appetite, difficulty sleeping, or depression. While both palliative and hospice care are designed to help people diagnosed with a serious or life-limiting illness, there are two main differences between the services. Palliative care may be provided at any stage of serious illness, while hospice services require a terminal prognosis. Palliative care can also be provided at the same time as curative treatments and therapies, while hospice focuses on comfort using a holistic approach to manage end-stage disease. Hospice provides a comprehensive care team and plan of care to support the increasing needs of patients and families. We talked a little bit about what is palliative care, improving quality of life, treating symptoms. And palliative care does collaborate with your physician, other healthcare providers, can meet your goal and helps ensure that you're in the right place for your serious illness. Pain and symptom management, comfort is of the utmost importance. So who would come out to treat you if you were under palliative care? You would have a nurse practitioner discussing with your medical providers your care every 2 weeks or every month, depending. And that person would be working closely with you and your family to help you make decisions as you move forward. I think a big part of the benefit of palliative programs can be to encourage folks to focus on advanced care planning, which is something that's really, really important to help those providers to know what your goals are and what your wishes are. That's something we talk a lot about in the month of April, which is National Healthcare Decisions Day, April 16th. I'm a big advocate for folks filling out their advance directives. Something else about the story I shared in the beginning of my talk, the family had never talked about hospice or palliative care, and the patient himself was only ever able to say whatever my wife wants, and he didn't want to talk about it, and he didn't want to fill out advance directives, and that left her with a big burden of trying to understand what the right thing was for him without having that documentation or even having the conversation. So all along his 90-day stay at the facility, she was having to guess at what he would have wanted. He really wasn't able to participate. Quality of life is what we were just talking about under palliative care. And you don't have to stop curative treatments if you're on palliative care. And who pays for palliative care? It is a covered service, and Medicare Part B, Medicaid, and some private insurances. The question about palliative, is it the same as hospice? Really, we're going to dig into that a little bit more as a more comprehensive program. Okay, so palliative care and hospice care really come into play when someone is medically ready to start having those types of conversations around end of life. And I think something that's important for us to really dig into and acknowledge is that your provider may not be the one who mentions it to you. It may be a neighbor or a friend or a loved one or a social worker in a facility or someone in the hospital mentioning that type of care. Have you thought about hospice care? Have you thought about palliative care? Would you be willing to have a conversation with someone about it? Is oftentimes the way that it is brought up. And then hospice or palliative care team member would bring it up to the physician if it's appropriate after meeting with the family. And I think that's something everybody on this call can relate to, having to go into family settings and talk with families about what their goals of care are is really an important part of being in the community. I'm going to pause here and ask if anyone has any questions that I might address before moving into the next part. Anything in the chat?
No, nothing in the chat. If you have a question, feel free to just go ahead and unmute yourself. And if you do have a question, while Kate is talking, feel free to put that in the chat. Anyone?
So you mentioned Who pays for palliative care? Who pays for hospice care?
Hospice care is also covered under most insurances, Medicare and Medicaid. I think that's a great question because if you do a side-by-side comparison, sometimes home health and palliative carry copay or deductible on the visits, whereas hospice is no copays and no deductibles. It's 100% covered and does come with a suite of services not included under palliative or home health. So we definitely want to look at some more of those things. Good question.
Anyone else have a question? So I have
Great.
I have a quick question, Kate.
Okay.
So are there any requirements, and when I say requirements, for insurance to begin either of these treatments?
So yes, there are some requirements for hospice care, not so much for palliative care, just the desire for more comfort treatment and some pain and symptom management really would qualify you under palliative. It's a little less stringent than hospice, if you will. To qualify for hospice care, you do have to have a life-limiting condition that a physician would say, and this is what's important to the Medicare language, that you have a 6 months or less prognosis if the disease were to run its natural course. And I love the question because I think that's a little hard to understand. What does that look like? How does that, look in real life? And oftentimes accessing hospice, people wait until it's too late. I think the concept of hospice is somewhat scary to a lot of people. And they use hospice when they feel like death is imminent. And really, hospice can be used for a lot longer time frame than that. The average hospice length of stay is 27 days. And it can be used for folks that, like I said, have a 6 months or less prognosis. What happens if they live beyond the 6 months? Anybody know? I know we have some experts in this room. What happens if we live longer than 6 months on hospice?
Yeah, that's a good question because we keep hearing stories about folks going, like your story earlier, in and out of hospice several times sometimes because they're doing well.
So if we have a loved one on hospice and they continue to survive and thrive beyond that 6-month timeline, hospice renews their certification. As long as they are still showing signs and symptoms of some type of decline and they're still with us, we can renew their certification and keep them on services. Sometimes we have hospice patients that are with us for 2 years, 3 years. Sometimes they discharge because they're stable and they have an extended prognosis beyond that 6 months because they've been doing well. They've been receiving good care in the home setting oftentimes, and their pain and symptoms are managed. So sometimes they discharge, they graduate. And then when and if they need the services again, they simply can call us back and we can come out and do another evaluation. So those are wonderful questions. All right. I'm going to see if I can show
if somebody graduates out of hospice, then they lose their care?
Well, that's also a very good question. If someone does graduate from hospice, Medicare won't pay for it anymore. And it is really up to the hospice team to try to connect back to the community services that they could take advantage of to make sure those needs are met. What I've done in the past when I do have patients that graduate is connect them back to home health or palliative in the community, working with their primary care doctor and make sure they have some support and some coverage. And then we do have a way of following up with families as far as every 2 weeks to every 30 days, calling them back, checking on them, seeing if they've had any changes that they could potentially use our care again, because you can always start another hospice stay when the time's right. But yeah, we do sometimes have to discharge people and try to connect them back into the community of other providers that can help them receive some care. Great questions. All right, true or false? Hospice pays for any durable medical equipment. Hospice pays for durable medical equipment that you might need. True or false? I heard true. Everybody thumbs up if they think that's true. I see some thumbs up. That is true. Hospice under the Medicare benefit is required to cover medical equipment. So as I was transitioning my patient to home yesterday from the rehab center, on Sunday, I ordered all the equipment. I got a Hoyer lift. I got an electric hospital bed. I got an air pressure mattress overlay to help prevent some skin breakdown. I ordered oxygen. I ordered a fall mat. I ordered a wheelchair. I ordered a bed alarm. I went to All Blessings Flow and got some hospital gowns yesterday for him. So all of those things that we order through our durable medical equipment do not come with a copay or a deductible, and they are delivered to the home. So by the time Monday afternoon transport came to the facility and we were able to transport this gentleman home, the wife had all the equipment all set up for him downstairs where he could be with the family. And that didn't cost him a dime. And before they started talking to me, they were looking at buying a Hoyer lift, which was several $100s. They were looking at renting a hospital bed. They were looking at an air pressure mattress, and they were thinking, how are we going to afford this? And I was able to meet with them and help them to overcome their fears about hospice and help them to access those that medical equipment at no cost, to be able to make his dream come true. This gentleman had been born in this house 95 years ago, and he wanted to go home and pass. I hope he's going to be with us a little while. I hope we have some time together. But as we've mentioned, sometimes people wait until they've exhausted everything else and then utilize the service. We're still happy to help people, even if it's late. But it would be wonderful if we could have more conversations earlier. In the email that I'm going to send after this, I sent it out once before through Anna, through this group. There is a wonderful handout that is a family conversation starter. And it goes through some prompts about what are your goals and your wishes and what do you consider to be a good day? Because quality of life is a big focus for hospice. And we really want to know what you consider to be a good day for you, and then kind of work from there as far as goals of care. All right, true or false? Hospice physicians can write orders for all the comfort medications.
True.
True. Absolutely true. They can write orders for your regular prescriptions as well. What about, do hospice patients still see their primary care provider? Do hospice patients still see their primary care doctor? Well, I think you could probably see it both ways. That may have been a trick question. Hospice does work with primary care physicians if they would like to attend a hospice patient. Then they can be part of the care plan, and we can send them documentations about our care planning, and they can write prescriptions, and they can bill for it under Medicare if they would like to participate. They don't have to go see the patient. The patient could go see them if they wanted to. There's just a few, rules about that. They have to let the hospice provider know that they want to go see their primary doc, but they certainly can do that. And that doctor can continue to be part of their care team, or that doctor can say, no, let the hospice physician manage the whole care plan and, I'll step out. So we really could do it both ways. Some physicians like to stay involved. Nurse practitioners like to stay involved. It really can be a community effort to take care of a patient and family at this time. So really, both are true. You can still see your doc and they can still participate, but you don't have to. Excellent.
You mentioned that Medicare can cover, hospice can cover all the medical equipment. What about palliative care?
So, good question. Under palliative care, you may still have copays and deductibles. You may not be able to access all the equipment that you could under hospice. There's a lot of rules that still apply under palliative care that treat it like home health. So, for example, for home health, you can only get one assistive device for walking every 3 years under Medicare. So if you got a walker, you can't also get a wheelchair, if that makes sense. If you got a rollator, you can't get a wheelchair. You have to only get one every 3 years. It's a good thing there's lots of places in Charlottesville that you can get complimentary equipment. Anybody know about All Blessings Flow? I hope you do.
Yeah, and there are a number of organizations here in Planning District 9 as well that do this kind of thing. A couple of the American Legion, and then there's another one over on the Fauquier side. So yeah, that's
Wonderful.
great service.
Wonderful. All right, I'm going to go into a little bit more detail about what hospice does include. I'm not sure that I've been able to really capture that. We've started to scratch the surface, but there's so much to it. So palliative care does not provide home health aides to come out and do a bed bath or a shower. Hospice does have aid services. To be clear, the hospice benefit under Medicare only provides that several times a week. It does not provide a caregiver all day. That is still something that folks have to either access family caregivers or private pay services for any kind of a standby assist caregiver all day. But we do provide an aide to come out and perform a task like a shower or a bath or nail care or hair care. They could change your bed linens as well and get you clean and fresh, but they only stay about 45 minutes to an hour per visit. And that care plan directs how many visits per week that the patient might have. So hospice includes a nurse for routine home care visits 2 to 3 times a week, depending. She or he would assess the patient, check their skin, check their breathing, check their vitals, ask questions, refill any kind of medications that are needed, do some troubleshooting, can even change wounds and do dressing changes. And that is an RN that's covered several times a week under hospice. Social work comes to the house, usually every other week, sometimes once a month, depending on the patient's wishes. And the social worker for hospice is in charge of your social and emotional needs. She or he also would be able to help you plan your funeral, make any arrangements you need, apply for Medicaid if that was necessary, making sure that she or he is finding resources for the family and solving problems. Sometimes our social worker goes to the point of going on visits to different facilities if you and your family wish to move you to a facility, for example, or an assisted living. Our social worker would be key to helping find resources. Chaplain services are included in hospice, and our chaplain is non-denominational, and this is for all hospices, not just Gentiva. I'm talking about all hospices here. A chaplain is provided, and it is part of the interdisciplinary team, and it is something that not everyone wants to take advantage of, but really, if you just would take an opportunity to meet with that person one time, you don't have to have them back. But it's often a benefit to have that person at least be a known figure, so that if later down the road you do want some chaplain services, you have someone who you've met before that could come in and provide emotional support and spiritual support. Again, a chaplain is non-denominational. That person will not talk about anything that you don't want to talk about. They are not there to convert you to any particular religion. They're there just to support you, answer questions, and be a shoulder, and a listening ear. If anything is on your mind or on your heart, that's part of it. Hospice is really a holistic approach, an interdisciplinary team that does provide these types of services to the home setting. We also have nurse practitioners that can be available for face-to-face visits. We can also access them for any kind of prescriptions. We have our medical director. We do have volunteers. Hospice is also part of a larger volunteer organization that we are required to have a certain amount of hours that volunteers do for hospice patients as part of the Medicare conditions of participation. So if anyone knows anyone who might be interested to become a volunteer, we're always looking for wonderful volunteers. What would a hospice volunteer do? I think it's important to note that hospice volunteers are not asked to provide any kind of personal care, any help in the bathroom. They wouldn't be providing a bath or a shower. They'd be providing companionship. It might be sitting by the bedside of someone in a facility on hospice and playing checkers with them for an hour. It might be bringing music in to a hospice patient's home. It might be just reading the newspaper with a patient. It's simply being present for them and being available. The requirements are very low. 1 hour a week is the requirement for a hospice volunteer. That's what we ask. And we, would love to provide more volunteers and match them up with more of our patients out in the community that could benefit from having someone, because often we do see folks that really don't have family close by, or they're in a facility and family doesn't come visit. There's a lot of challenges that folks deal with at this stage of life that we can help with. Hospice is really looking at the whole person, because we do believe that dying is not only a physical process, but it's mental, emotional, spiritual. The whole hospice movement was started in 1921 by a woman by the name of Dame Cicely Saunders in London, England. And she was amazing. She was a nurse, and she owned a small home. It was called the St. Christopher's Home. And she would take patients in to the home to give them a place to go to pass away. And she trained a lot of volunteers. The hospice movement started as volunteers only. No one got paid for hospice. And I think that was a really an amazing gift to give someone. Her belief was that you matter until the last moment of your life. And that was something that was new in that time frame. Oftentimes our elders are isolated or alienated, or depending on cultural values, they're not as valued. And she sought to change that. And that was 100 years ago. And she made a huge impact. So fast forward to 1980s, and hospice became what it is more closely today, because Medicare stepped in and became a pay source. So now hospice is a covered service that is available to anyone who's qualified for the service. It doesn't usually come with a residence or a house. Hospice is provided wherever you call home. There is a hospice house in Charlottesville. The Hospice of the Piedmont does run. It's been recently renovated and reopened and is lovely. And if there is an opening and your loved one would like to go there, there's a screening process. But that is one of the only places that I know of. There's one or two out in the Stanton-Fishersville area. There's one in Williamsburg, and there's one in Northern Virginia that's a hospice house. But really, it's very unusual that a community has that. So that's a nice resource for folks to take advantage of if possible. They used to have 8 beds available, and I'm not sure with the renovation if that number has changed, but it is something to look into. But the need for that is far greater than 8 people at a time in the community benefiting from a place to go. So agencies like Gentiva, Legacy, Medi, Hospice of the Piedmont, we all try to make hospice as comfortable and peaceful as possible wherever the patients call home, whether it's an assisted living, skilled nursing facility, or sometimes hospital. So there's 4 levels of hospice care. The one I'm talking about the most is called routine home care. And that's where I'm talking about a nurse coming 2 to 3 times a week, an aide coming twice a week, so on and so forth. That's the frequency under routine home care. There's also crisis care hospice. And that is when a nurse and a doctor can agree that there is a situation that is becoming unmanageable for that patient, whether it's pain or symptoms or something like bleeding that, becomes a crisis. And under Medicare, you can send an RN or an LPN for 8 hours, up to 8 hours, to manage a crisis if it's an acute situation. And hopefully by then, the nurse and the doctor have been able to manage whatever the pain or symptom is and go back to routine home care. But that is one of the levels of hospice care that is available. Another level of hospice care is called respite care. Respite care is when a home patient and their family caregivers decide that they need caregiver respite, a break, right? So hospice covers 4 nights and 5 days at a participating skilled nursing facility. So let's just say our family that we just took home yesterday, the wife is going to get some surgery and she needs about a week to recover before she can come back to caring for her husband. So we can coordinate with one of our partnership facilities, the Cedars, Charlottesville Health and Rehab, Autumn Care Madison, a lot of those facilities that we collaborate with, and we can pay for under the Medicare benefit a 4-night, 5-day stay of care at a facility while the wife is getting her surgery. And then when that time is up, she can either pay for him to stay a little longer if she needs more time, by the day, or if she's ready to bring him home, we'll bring him home. Hospice pays for the transportation, equipment, medication, and care over at the facility for that respite stay. Questions about, I just gave you a lot of information, a lot of nitty-gritty questions about different levels of hospice care. They're all covered under insurance, everything I've just talked about.
Anyone have any questions? Feel free to unmute yourself and ask.
Okay, the last level of hospice care is called general inpatient care. And that is something that a lot of people don't really understand. When someone goes into the hospital and the physician determines that they're actually in the dying process, folks in the hospital, that are in the hospital, they think, well, we can just stay here right? And we'll die here, and it'll be fine. I'll just get hospice here. And sometimes that works, but often you don't meet the criteria for general inpatient hospice care in a hospital. So you have to make a plan to go somewhere else. And that's where a lot of times those care transitions take a lot of planning, and people don't understand why they can't stay at the hospital. The hospital is for people that are being treated for something. And typically, when you just determine that you're going on hospice, you're being treated for comfort. You're not being treated with IVs and aggressive measures. And so the hospital they can't really keep you. Okay. The hospital is for people that are looking to get better. So when you decide to go with hospice and you're in the hospital, you need to make a discharge plan. This is where advanced care planning really could be helpful. But generally, for inpatient hospice criteria to be met, i.e. to pass away in the hospital on hospice, you have to be critically acute in a stage where that's the only level of care that could manage your physical situation. So ventilator, IVs with aggressive medication. There are a couple of ways that you could access general inpatient hospice care. But again, it has to be very acute situation, and it's pretty rare that level of care is accessed. I think less than 1% of all hospice patients are general inpatient hospice patients. Most people are routine home care or at the skilled nursing facility level. All right, Anna, what have I not covered?
My, you've covered a lot. That was really, really informative. Yeah, I think I learned a few things.
Mm-hmm.
Yeah.
All right. I want to share my last story, and that is kind of a celebratory story. Somebody asked me a little earlier in the program how long you could stay on hospice. And I just want to kind of point out that former President Jimmy Carter is on hospice care currently in his home. And he has been on hospice care for 14 months. And he celebrated a birthday recently, and he's been very public about his hospice journey. He was a pioneer in healthcare and advocacy back in the 60s and 70s. He and his wife started the Center for Medical Research. They really were, they made a big news media about choosing hospice care to try to help dispel some of these myths and debunk some of the things that we just talked about today. So if you have an opportunity to Google Jimmy Carter, he's got a lot of insightful information to share about his hospice journey and about why he chose to go with hospice and how it's been already 14 months. And I think a lot of times people have the impression that you're choosing hospice and you're going to pass away tomorrow. And really, that's just not the reality for most people. What does it look like to be a hospice patient? Well, you can still be enjoying life. You can still be walking, talking, eating, drinking, home with your family. The only thing you really, have to have is a life-limiting illness, which part of my talks in the past, we've gone over what does a life-limiting illness look like? And most people say, well, it's cancer, right? It's really for cancer patients. And that's definitely one of our top 5 diagnoses. But would it surprise you to know that the actual number 1 diagnosis for hospice patients is Alzheimer's? Alzheimer's is a terminal diagnosis. Unfortunately, we haven't found a cure yet. I hope we do. But that is a terminal diagnosis that will take your loved one's life at a certain point. And so A lot of people don't realize hospice is utilized for Alzheimer's patients that have started to decline, congestive heart failure patients that are using oxygen or short of breath. We have patients that have COPD, which is chronic obstructive pulmonary disease. We have patients that have renal failure, liver failure. Those are really the top 5. Parkinson's is probably number 6. So those are a lot of the hospice diagnoses that people don't think of when they hear the words hospice. But what does it look like to be a hospice patient and be eligible? I think this is also important to tuck this away, is that you have probably experienced emergency room visits, infections, maybe you've had some falls, you've been in and out of the rehab center, and you're just not seeing improvement. In fact, your quality of life is declining. And people ask me, well, how do I know when? When is it appropriate? And it's really a combination of 2 things. When you're interested in more comfort treatment, you're no longer interested to pursue aggressive treatment at the hospital level. And when your doctor says you may qualify. Those are 2 things that actually could bring you to this place to access the services. But the hallmarks of someone with a terminal prognosis who's experiencing those things at 6 months or less is that hospital to rehab center to home, back to the hospital, back to the rehab center, trying to get home. You've been home for 3 days and you got another urinary tract infection and you're back in the hospital. Odds are very, very good that you would be eligible for hospice care if you would have a conversation about that, and set up, goals of care conversations with the hospital staff. The social worker there would help you. There's a palliative care team there would help you at the hospital. Have those kinds of conversations so that you could make choices to enjoy the time you do have. Go ahead, Anna.
I was just going to say we have one question in the chat. How about stroke survivors for palliative care?
Absolutely. So there is a hospice diagnosis called late effect CVA, and that is someone who's had a stroke, who is not returning to a baseline, who is continuing to show signs of declining. Maybe what that looks like usually is trouble swallowing, losing weight, not able to participate in therapies. Palliative care, you can be doing your therapies and whatnot. Hospice care, therapy would be wrapping up and transitioning over to hospice. But yes, that is definitely a hospice diagnosis. You also usually see skin breakdown, less, functional mobility. Maybe you were with a wheelchair or a walker before, and now you're wheelchair bound. That's a good question. Yeah, stroke patients can benefit significantly from palliative and hospice.
Great, thank you.
Good question. Different kinds of dementia. Alzheimer's is not the only one. Who can name another kind of dementia? Dementia being the overarching diagnosis, but there's
Lewy
several.
bodies,
Lewy bodies, excellent. Yep.
frontotemporal.
Frontal temporal. Yep. Vascular, which is usually someone who's also got maybe some history of stroke, etc. So all of those diagnoses are hospice diagnoses. Who said that?
That was Mary.
Hi, Mary. Thank you for that.
Hi. Yes, my husband is under hospice care and has been for almost 11 months now for Alzheimer's.
Oh, wow. Well, I'm glad that you accessed the services.
Yeah, it's been wonderful.
I'm glad to hear it. Do you want to share anything about it? You're welcome to.
Well, I'm just very pleased that it was suggested to me and explained to me, and he is in a facility. He has been recertified about 3 times the last one being this week. They thought he might have reached a plateau and wouldn't be eligible, but he had apparently lost some weight, so that made him eligible. But yeah, it's been a wonderful service, and all the people associated with hospice have been a tremendous help and very kind and caring.
Thank you, Mary. I appreciate that. That's a really good reminder. As we touched on earlier in our talk, the Medicare guidelines say 6 months or less, but if you continue to survive and thrive, we recertify you as best we can. I'll also tell you something. If you were to have gone down the path of being discharged, there is an appeal process. So keep that in your back pocket. You can appeal to Medicare if you do not want to be discharged.
Oh, that's good to know. Yeah.
Mm-hmm. Mm-hmm. So hospice doesn't cover the room and board at the assisted living or the skilled nursing facility unless you are a long-term Medicaid recipient. That is when hospice can be provided at a skilled nursing facility with room and board covered. That is the only way that it is a covered service that includes a room and board benefit, is if you are a Medicaid recipient. Otherwise, room and board is up to the patient and the family. And I know some of you on here work for maybe assisted livings or skilled nursing homes. And, folks have to understand that they would be paying out of pocket for room and board unless they are a Medicaid recipient if they want to receive hospice at a facility. Hospice itself is the covered service, but the room and board is still be on the family or the patient. Long-term care insurance, I am a big believer because that is a wonderful way to plan for the future. I'm not a financial advisor anymore, but if you want more information about that, you can reach out to a financial advisor. But that would be a way to cover your room and board costs if you were to need to go somewhere for that, for residential living. All right, what is the difference between advanced directives and a DNR? Anybody?
DNR is
All right.
do not resuscitate.
Mm-hmm. It is a separate piece of paper that has a stop sign on the top, and it's signed by a physician. So it's a doctor's order to do not resuscitate someone. Advanced directives is a different form. It could include language around your wishes for resuscitation or not, but it is also more comprehensive, and it talks about what kind of treatment you want or don't want at end of life. Do you want a feeding tube to hopefully, to prolong your life, or do you not want that level of intervention? Do you want a ventilator to prolong things, or do you not want that intervention? There's a lot more to it. That's a whole nother talk that we can do another time. But I'm always, encouraging folks to take advantage of filling those out either in your doctor's office, the advanced directive, or at a skilled nursing or an assisted living. All of those folks in those places of service are able to provide you with advanced directives if you would like to fill those out. And I can be available to answer questions. I know it's 5 minutes to 1. I certainly appreciate everyone having lunch and learn with us here. And I'm happy to answer questions. I can stay on, or you can reach out to me on my cell phone or in my email, which Anna can put in the chat, or follow up with an email later on.
So I don't have any questions, but I do have some personal experience to share, and I want to lead with thank you for doing this presentation. Ugh, I didn't anticipate to cry.
It's okay.
So both of my parents have passed away from cancer, and I'm a cancer survivor as well. And so we had hospice for my mom, And it was, you know, it was really helpful. It was great. I was really impressed with how quickly we were able to get a more comfortable bed, or at that point she had a hard time like swallowing pain medication. And so they were like, they just had solutions on hand for everything. And it was really amazing. With my father, so my mom died in 2010 and my dad died Christmas 2021. And it was he declined really quickly. And I'm just curious about why providers aren't recommending that, or recommending it sooner, or even just the awareness. It was shocking to me. And when my dad died, I was there with them. And I didn't know who to call, afterwards. So I'm like, well, I guess I'll call 911, thinking that it was going to be the same as it was for my mom. And it was absolutely not at all. They ended up, the police came, and then it ended up being them accusing me of elder neglect. And then they turned it into, like a suspicious death. And this was all just immediately after his passing. And it was just so way more traumatic than it needed to be. And I had talked to my dad that morning and I was like, hey, I really think like we should call hospice. And the way my mom explained it to me, because when I heard hospice, I was devastated. But she told me that it was a tool to help her get stronger and better. So that's why I told my dad, I was like, well, this was for mom and it was helpful. But he was like, no, I don't want to. And it was like, how can I go against those wishes? And because I felt like a duty to ask him. And then he just declined so quickly over the next like 3-4 hours. And I had decided, I was like, well, like I'll call in the afternoon. And it was just that amount of time.
Oh my gosh.
It was just so shocking. And I'm just like, even his doctor, I don't know if you guys have any experience with Virginia cancer specialists. But he was doing radiation 5 days a week and he's not showing up for appointments. They did not call. They did not like ask why. I tried to get his pain medication refilled and they treated me like I was a pill seeker. And then they were even calling after he had already died to see, like, they're like, oh, well, he missed his appointment. And I was like, you guys signed the death certificate. Like, what do you mean? Like, it was just such a crazy, crazy experience. And I don't
I'm
know.
so sorry. It
Yeah.
sounds just awful for you. Oh my goodness.
I just like, where's the disconnect? Like, I don't know.
I think you kind of answered your own question in a way, in that providers don't really, they want to do the next thing that they have in their arsenal to do. They want to treat.
Right.
If they can treat, they want to treat. If
Yeah.
they offer you, a blood transfusion or something, they want to offer that to you.
Right.
Not thinking about the larger picture of
Yeah.
what are the real goals here, what's realistic to expect, how can we help you to take, dad to the next step.
Yeah.
They're just kind of looking at their piece of the puzzle. In the medical community, we've made great advances in, what we can and can't do. We can do a lot of things to keep people alive for a long time, right?
Mm-hmm.
Just because we can doesn't mean we should. And I think
Yeah.
more of this conversation needs to happen around the tables at home and, in doctors' offices, and just even you all being here today to hear what I had to say, and now to hear Chelsea's story and Mary's story. you're going to be able to help somebody else, I hope, because the more we can talk about it, the more we take that stigma away of talking about death. That's not going to make death happen any faster just because we talk about it.
Right,
But
exactly.
it could have helped you, Chelsea, to not experience what you went through. My heart just breaks for you.
I thank you. I was just,
Hospice
Oh.
is really trying to help, you know,
yeah.
bring that conversation around and have family experience peace, experience symptom management and pain management.
Absolutely.
But you know, when people don't want to have the conversation, it's hard for everybody. So I just
Whenever-
appreciate you being
I know
so honest.
we're about to go, but I always, because I'm obviously have a passion about it now. And it's just like, America doesn't know how to die. Like it's not, it's so different in other cultures.
Absolutely. Absolutely. We are a death denying culture. And so anything that you can do to spread the word and have those conversations, I'll
Thank
send you
you.
guys
Yeah.
some literature. I appreciate you all
Yeah.
sharing.
Thank you
1 o'clock.
so much, Kate, and thank you, Chelsea and Mary, for sharing those personal experiences. That's so important. Thank you so much for your time, Kate. We have come to the end of our hour, but thank you all for joining us. And yeah, let's all help spread the word and share the truth about hospice and care. So thank you so much.
I
Thank
appreciate
you.
it. Thank you guys so
Thanks,
much.
everybody.
Bye-bye.
All right. Bye.